Thank you, everyone. So we have our final speaker before we will break for morning tea, which will take place outside. So our session with Associate Professor Andrea Phelps will continue right through to 25 to 11, so a half-hour session, not long to go. And what a pleasure to meet another fellow Tasmanian who now calls Melbourne home. Associate Professor Andrea Phelps is the Deputy Director of Phoenix, Australia, Centre for Posttraumatic Mental Health. She has over 20 years of clinical experience in the assessment and treatment of post-traumatic mental health problems and was responsible for the accreditation of PTSD treatment programs for veterans across Australia for many years. Please make her very welcome.
Thank you very much for the introduction, and thanks very much for having me here today. So I'm from Phoenix, Australia, Centre for Posttraumatic Mental Health, and we're a not-for-profit organisation affiliated with the University of Melbourne, but our mission is really to improve outcomes for people affected by trauma. So that means working with people who are directly affected, as well as workplaces who are responsible for workers exposed to trauma in the course of their duties. And I've learnt from Kim that the green button is the onward button, so thanks for that. So when we think about trauma exposure in work settings, there are two types of exposure, broadly speaking. The first one is direct, where people in a work setting can be actually directly, physically, sexually assaulted, be involved in motor vehicle accidents, but also less obvious things in a sense. Things like having to view objectionable materials, so either terrorist-related images or child pornography images. We know that investigators who have to do this sort of work repetitively can be really quite affected and impacted by it. There's also, in workplaces, indirect exposure. So this is where people have to, in the context of their work, repeatedly hear the stories of other people's trauma. That in itself, we don't call that a criterion A event, as has been described previously for PTSD, but people can certainly have some secondary trauma from that sort of indirect exposure. And it's important to recognise that in some workplaces, there is a foreseeable and predictable risk of these sorts of exposures. And we heard earlier about the enormous cost of PTSD, not only for the individual, but also economically and socially as well. So it really is incumbent upon us to do everything we can to prevent the development of PTSD. When we're talking about trauma exposure in workplaces, it's also important to recognise that these occur in the context of the individual, and for some there might be some particular vulnerabilities that they bring with them. So personal histories can be a factor. But also the routine operational stresses, so shift work, fatigue, when people are having to work in a time-critical way, low control over their job, low autonomy, and also organisational stresses, so management, supervision, leadership, the sorts of environment, the climate, whether someone's got really clear role, boundaries, demarcation, and whether they're working in situations where they've got good resources, adequate resources. All of these factors can impact on the extent to which a traumatic exposure is likely to lead to post-traumatic mental health problems. So there's this recognised link between routine, operational and organisational stresses and PTSD. Where there is a high ongoing level of stress, it probably means that the person is just, as Kim was talking about the stress bucket, that if you've got a high level of stress in your everyday working life and then you have a trauma on top of that, you've probably got fewer psychological resources left in reserve to tackle that. There's also a really important link between organisational support after a potentially traumatic event and PTSD. We know that for anyone who's exposed to trauma, social support is actually the best predictor of recovery. That's critically important. We can't necessarily do anything about pre-existing vulnerability. We can't necessarily do anything about the exposure itself. The nature of people's work means that some people will be exposed to trauma. But what we can do is ensure that we provide the best practice response after someone has been exposed, and I'll talk more about that. So this is not to say that the traumatic event itself doesn't cause the problem, but that good organisational support can serve to buffer the impacts. We've also noted through various research that there's a link between morale and resilience. So teams with low morale typically have the highest risk for psychological injuries and absenteeism. Cumulative trauma has been mentioned already by both Kim and Zach. And in work settings, we know that the issue is more often accumulation of potentially traumatic events. What we very often see is that along the way, people seem to be coping okay, and it seems as though the effects are sort of managed or contained by being part of the team, having the support of the team. But what we find when we talk to people, when they look back, they say in retrospect, yes, there probably were growing signs along the way of being irritable, being more short, having a short fuse at home, not sleeping well. And then it might be a particular event that then triggers the PTSD. So whether it's because a victim might strike a chord because of a personal connection, or it might just be the last straw. So in workplaces, we have this increasing recognition of responsibility for workers. But the key challenge here is that while we've got good evidence about what are the best practice treatments for PTSD, which Kim, I think, will be talking about this afternoon, the key challenge in the organisational setting is that the evidence about what we can do to prevent PTSD is not as strong. Phoenix developed the Australian guidelines for the treatment of PTSD. These are approved by the National Health and Medical Research Council, supported by the government and endorsed by all of the professional colleges. We've also got specific guidelines that have been based on the Australian guidelines for PTSD, but this is led by Sam Harvey and his team at the Black Dog in Sydney, that have really adapted the guidelines to the emergency service sector in particular. When we go back to the Australian guidelines, that they really do, even though I say the evidence isn't strong of what we can do preventatively, the guidelines do cover this scope. And so where there's not good, strong evidence, there is what we call expert consensus opinion that we can draw on. So that covers off on things like pre-incident preparedness, post-incident interventions for anyone. Not a matter if they've got symptoms or not, but what do we do for anyone who's been exposed to trauma? What should we be thinking about in terms of screening and assessment? And then for those who do have an acute stress response, what are the best practice treatments? What are the best treatments for people who develop PTSD? And then what should we be thinking about with respect to rehabilitation? I won't go through this in a lot of detail, but just to say that the methodology for developing guidelines is a very rigorous one. We're just going through the process at the moment of updating the guidelines, so it's all very fresh in my memory. But it's a very rigorous process where we decide what the key research questions that need to be addressed within the field are, and then we select studies through a systematic review of the evidence that are of the highest quality. So we're really looking for randomised controlled trials where we've got a high degree of confidence that the effects that we're seeing are due to the intervention and not due to some other spurious connection. We then grade the evidence, and for each intervention, within each research question, we look at what the evidence tells us, and then we develop recommendations on that basis. The guideline recommendations are then graded from A, meaning we're most confident in this, through to D, and then for areas where there's not enough research or no research, as I say, we rely on expert consensus opinion. The key recommendations, so firstly around pre-incident preparedness. All we can say at this point, despite all of the research that's going on around resilience training and all of the money and effort that's being put into resilience training, all we can say, and it's a consensus point because we don't have good research evidence, is that for adults who are likely to be exposed to a potentially traumatic event, pre-incident preparedness training may help psychological adaptation following the event. It's a bit disappointing, really, when you look at the amount of work that's going on at the moment. So we certainly would recommend that organisations do engage in pre-incident preparedness, but critical that we try and evaluate the outcomes of that. There's so much that's going on, but the research is not there to support it. When it comes to post-incident, what we do know is that a single session psychological debriefing shouldn't be offered on a routine basis as a preventative measure. This again was in widespread use, psychological debriefing. When the research was eventually done, they found that it wasn't effective in preventing PTSD, and in a small number of cases actually made it worse. And the reason we think that occurs is that everyone has their own coping style, and if a coping style, i.e. talking in detail about the event, is forced on someone when that's not their natural coping style, it might actually be counterproductive. Oh, sorry. So, yeah, sorry. So the recommendations in the guidelines are more about what not to do rather than about what to do, unfortunately. So it really is about just, rather than getting people together and talking in detail about the event, still getting people together. I think people appreciate an organisation's recognition that they've been through a very difficult event, but it's more about providing practical advice and support and information. People who do want to talk about it should be given the opportunity to do that. We're not saying not to talk about it, but not to force people if that's not what they want to do. And what we really recommend is this notion of a stepped care approach, whereby people who are known to the individual, and that might be their supervisor or line manager, are monitoring the well-being, just keeping an eye on people over the few days and weeks after a traumatic event, and just checking in with them to make sure that they are okay, and then providing or referring a level of care commensurate with how they're going. Those who are going fine don't need anything else, but those who are struggling a little bit, that would be the time to consider referral. When it comes to acute stress disorder, so this is for within the first 4 weeks after a traumatic event. If someone has the signs of PTSD, we call that acute stress disorder. And what we know is that trauma-focused cognitive behavioural therapy is the best approach. So you don't want to be waiting a few months down the track if someone is developing symptoms. You do want to get in and start providing treatment. As you'll notice there, it's a grade C recommendation, so there's not as much evidence as there is for when it has been longer. So when someone's developed post-traumatic stress disorder, Grade A recommendation, so the highest level recommendation we've got, is that trauma-focused cognitive behaviour therapy, or EMDR, eye movement desensitisation reprocessing, should be provided. And from the very beginning, there should be a focus on psychosocial rehab. So we don't want to just try and provide treatment for the symptom relief and then think about broader rehab. We actually want to be doing that from the outset. So how does this all apply in workplace settings? When we work with organisations around trauma management policies and procedures, we think about 4 key elements. The workplace culture, which we've heard already is critically important, pre-incident preparedness, the actual incident response itself, and post-incident response. And these recommendations or advice are really informed by the guidelines, but also what we know about the established risk and protective factors and what we know about evidence-informed treatments. So the first issue around building a supportive workplace. As I've mentioned, there's really this critical recognition of the importance of staff morale. And that staff morale, we know can be contributed to by a number of factors, but critical to those are leadership and adequate role clarity and adequate resources. So whatever organisations can do to ensure that those factors are in place is likely to improve staff morale. Also critically important that the recognition of mental health and the need to support staff within organisations is being heard at all levels of the organisation. So from the most senior leadership down. We really need, in organisations where senior leaders are prepared to get up and talk about perhaps their own experiences with trauma, their own need for support from time to time, that's critically important. At the level of pre-incident preparedness, what we're talking about here is policies and procedures for managing traumatic events, our staff education and training to ensure that the appropriate support is provided. And this is where training, it's not just about mental health practitioners knowing how to provide appropriate responses, it's also about people in the workplace. So if you've got an immediate line manager or supervisor who understands the nature of trauma and the impacts that it can have, they're going to provide a much more empathic and helpful response to someone than someone who is uninformed about that. So those sorts of policies at the organisational level, and then at the individual level, as I said, there's no proven resilience training, but it is important that people have information and understanding about what to expect in their work. So a good example of this is we've done some work with TrackSafe, the rail industry peak body, and the number of train drivers I've spoken to who said that no one ever told them that people suicide on the train. No, they had no preparation for that before joining. So that's sort of a realistic job preview. This is the sort of thing that you may be exposed to. Information about potential reactions and also self-care strategies are all critically important. When it comes to the incident itself, the sorts of policies and procedures that we encourage are things like how you manage the actual scene. How do you manage a scene in order to minimise the risk, minimise the exposure? So minimise the number of people who have to be exposed to that scene, minimise the length of their exposure, and where you can minimise their exposure to the grotesque elements. So people who don't need to be at the aftermath of an accident, for instance, shouldn't be there. People should be moved away from the scene, only those who need to be there, as an example. A second element is minimising cumulative exposure where we can. And this is very difficult in an emergency service context in particular, where this is part of the job. But if there is a recognition and a record keeping of who's been exposed to what you're trying to do is to minimise the circumstances where someone has been through 2 or 3 really difficult jobs and then they're sent to another one that you know is going to be difficult, so that they're just trying to be mindful of that cumulative exposure and managing. The third point there is when people are in an incident that is traumatic for them, we believe that it's helpful to support people in doing the job that they need to do. So if someone is overwhelmed by their own response and not therefore doing the work that they're meant to be doing, that can compound the impacts. If possible, helping people to focus on the job and what they're meant to be doing while they're there before they have to leave. And that's really the case where people have to stay on the site. If they can leave the site, then that's okay. And then post-incident, so monitoring, providing information, providing emotional and practical support. And this is what we generally call psychological first aid, and it has really replaced psychological debriefing as the best practice approach in the immediate aftermath. Not for people who've got symptoms, but just for everyone. And then given the variability in responses, interventions also require flexibility. So tailoring approaches to the individual rather than thinking a one-size-fits-all. And this is where we come to the stepped care approach. So what about the role of peer support? We know that increasingly peer support services, teams are set up in emergency service personnel. Despite how widespread this is, there's not actually a lot of empirical support at this point. And again, just really emphasise, if this is something that you're connected with or involved in, the importance of evaluating peer support is critical. In the absence of high-level evidence, there are consensus guidelines, international consensus guidelines that we led, Mark Creamer led a number of years ago, but are still very current. And these guidelines look at 8 areas when you're setting up a peer support program relating to the goals, being clear about what the goals of peer support are and aren't, how you select peer supporters. So it's not just by people who volunteer, but you're wanting to have the right sort of people involved, who've got the right sort of interpersonal skills, but also the level of stability and probably having been in the job for a reasonable length of time to have a good idea of what's involved. Training and accreditation of peer supporters is critical, so that we're not putting people into situations that they don't feel adequately prepared for. The international consensus guidelines do say that it's important to have mental health professional involved in peer support programs, so it may be leading the program, providing some supervision, for instance. The role of peer supporters needs to be really clear. We've had many examples where peer supporters themselves have become distressed and have suffered as a result of that, probably because they've become over-involved and haven't had clear boundaries around what they can and can't help people with. And that can be difficult for anyone working in a helping profession, but if it's a peer supporter who's also involved in the job themselves, that probably just compounds it. So really important to have clear role boundaries. Access to peer supporters, how do people access them? What are the parameters and limits set around that as well, so that peer supporters aren't at the beck and call 24 hours a day, 7 days a week. We need to have policies of how to look after peer supporters, supervision, support, making sure that they've got their own self-care plans. And then the 8th point critically is around program evaluation. And I just emphasise that again because with all of the interventions that we put in place, most of them are based on what we are pretty confident is going to do no harm and what we think is going to be helpful, but we need more research. The stepped care approach that I've referred to is really this sort of 3-level approach. So at level 1, where the intervention is psychological first aid, that practical emotional support and just monitoring well-being. So the target group for that is everyone who's been exposed to a trauma. And that can be delivered, it doesn't need a mental health practitioner, that can be delivered by peers and supervisors. You want to train the peers and supervisors in how to do it, but that would be perhaps a one-day training. Level 2, the target group for this is people who just don't seem to bounce back. So they haven't developed a mental health disorder, but they haven't bounced back. So they might just be showing signs that they're not quite back to normal. And here what we're looking at is evidence-informed skills practice. So it's sort of the building blocks of cognitive behavioural therapy in a way. So things like problem solving, activity scheduling, helpful thinking, and building social supports. And again, that doesn't need to be developed by specialist mental health practitioners. People can be trained, so whether it's peer support, employer support, EAPs can be trained in providing that level of intervention. And then level 3 is really the specialist mental health intervention, evidence-based trauma-focused treatment, and that's for those who have developed a mental health problem, whether it's PTSD or, as Kim mentioned earlier, a range of other mental health disorders, but that's when you do want a mental health specialist involved. So this is the Phoenix Australia sort of trauma management framework. I don't know if you can see the details clearly there, but it really does just bring together the way we think about this as very much a holistic, whole of organisation approach. So in the outer layer there, we've got senior leadership. So critical that senior leaders are on board, that they're giving the right mental health messages. They're not only talking the talk, but they're also walking the walk. But that needs to be communicated to the workforce, that at the most senior level, people are aware and support mental health. The next level within that is the policy framework, that we need to have the right policies that address how we're going to manage trauma exposures. In the next circle on the inside is primary prevention. So this is how we maintain a mentally healthy workforce, and that is things like the morale, the psychological resilience and well-being, the pre-incident preparedness, all of the stuff that we're doing for everyone to try and maintain a healthy workforce. Then we've got the secondary prevention for those workers who are experiencing some symptoms. So we don't want to wait until they do develop a mental health problem. We want to get in quickly and address that. And then at the tertiary level, the specialist mental health level, for those workers who have developed a mental health problem, that we need to make sure that they're getting evidence-based treatment. Unfortunately, we know that the uptake of evidence-based treatment amongst psychologists isn't as high as it should be. So if you're the person in a workforce who's responsible for sending someone off to see a mental health practitioner, it's critical that you actually find out what service they're offering. Don't assume that it's going to be evidence-based practice, but take the trouble to find out what they're doing and find someone who will provide that evidence-based treatment. Down the side of the model, you can see self-care that runs through primary, secondary and tertiary. we really do believe that it's very much a shared responsibility between the individual and the organisation, and self-care is always part of the response. It's always part of best practice approaches, whether the person has some symptoms or doesn't. And then down the other side of the diagram is the screening and stepped care, so that screening can be quite formal, as in doing a survey of people and measuring their mental health, but it can also be quite informal, where it is just people checking in with each other or supervisors checking in with staff to see how they're travelling, and stepped care being at a level appropriate. And then around the outside, we've got this ongoing review and improvement. So it's a continuous process of ongoing review and just getting better and better all the time, evaluating what we're doing, seeing what's working, and being prepared to adapt and adjust in an ongoing way. That's time. Thank you very much.
Thank you very much to Andrea. That wraps up our morning session. Morning tea will take place outside and we will start at 11 o'clock. So we'll see you back here at 11 a.m.